Yes, Doc, loud and clear.
Okay. So this is the WHO dengue update, which was released on October 8, 2020. It says here that from January 1st to September 19 of 2020, we have a total of 66,623 dengue cases with 258 deaths reported. This is actually 80% lower compared to the 335,064 cases reported in the same period of 2019. So, dengue is an acute febrile illness caused by an infection with any four serotypes of dengue, the dengue 1, 2, 3, and 4. It is passed from human to human by the bite of a female mosquito. Infection confers lifelong serotype-specific immunity and short-term, which is 2 to 3 months cross-immunity. So humans can have 4 infections in a lifetime. So dengue begins after an incubation period of 5 to 7 days, and the course follows 3 phases: the febrile, the critical, and the recovery phase. For the febrile phase, it usually lasts 2 to 7 days, characterized by high temperature, associated with myalgia, headache, retroorbital pain, aches, and rash. It is during this phase wherein a clinician can have difficulty in differentiating dengue from other febrile illnesses. After after the febrile phase, you have the critical phase. This usually occurs on day 4 to day 7 of illness. It coincides with effervescence. So most patients clinically improve during this phase, but those with significant plasma leakage, they develop severe dengue as a result of an increased vascular permeability. So what happens during the critical phase? During critical phase, there's increased vascular permeability leading to significant plasma leakage and the development of warning signs followed by the clinical deterioration of the patient. These usually last 24 to 48 hours, and without proper treatment or intervention, death follows. So do all dengue patients enter the critical phase? Not all patients will experience the critical phase. So what happens to patients without significant increase in vascular permeability? The fever subsides and there is a general improvement in the condition, as well as the appetite, though the patient may still have leukopenia and thrombocytopenia. So what is the picture of a patient in recovery phase? During recovery phase, there's a gradual reabsorption of extravascular fluid in the next 48 to 72 hours. You will have the following clues or clinical clues for the improvement of the general well-being with stable hemodynamic status. This is also accompanied by diuresis. Patient's hematocrit stabilizes or may fall due to the dilutional effect of the reabsorbed fluid. WBC starts to rise, followed by the recovery of your platelet count. There is also the appearance of your Hermann's rash, which is characterized by the Isles of White and the Sea of Red. So this slide shows you the phases of dengue illness and the expected laboratory changes. So during the febrile phase, you will see a downtrend or decreasing level of your WBC and platelet and increasing level of your hematocrit. Patient may experience poor oral intake, thus dehydration and inadequate urine output are noted. And during the critical phase, defervescence occur with increased hematocrit level. It is at this phase where shock occurs because of significant vascular permeability. And during the recovery phase, there is clinical improvement and laboratory value stabilizes. So let's go now to the classification. In November of 2009, WHO proposed dengue classification. It is classified by severity: dengue without and dengue with warning signs and severe dengue. So patients' classification changes as the illness progresses with time. So a patient with probable dengue should be followed up to see whether he or she develops warning signs or severe dengue. It is usually from day 3 to day 7. So if the patient's temperature comes down and general condition improves, he or she has dengue without warning signs. And if the patient develops the warning sign during the transition from febrile to afebrile, there is a high risk of developing severe dengue. And all dengue patients with warning signs require close medical attention. So dengue fever is non-specific and presents like many other diseases. Thus, many conditions and illnesses should be considered in the differential diagnosis. So clinical and laboratory pictures of dengue change as the disease progresses from febrile to critical and evolves into recovery phase. So patient may present to clinicians at any phase of dengue illness. So in early febrile phase, as I have mentioned before, it is not easy to differentiate dengue from other febrile illness as its features mimic many other febrile illnesses. History taking should focus on whether or not the patient is living in a dengue hotspot. And if the patient is not living in a dengue endemic area, then a history of recent travel to dengue endemic area may raise clinical suspicion of dengue. In early febrile phase, dengue can mimic other flu-like illnesses. And these are the conditions that mimic the febrile phase of dengue. However, because of the COVID-19 pandemic, healthcare providers need to consider dengue and COVID-19 in the differential diagnosis of an acute febrile illness. As dengue disease progresses into critical phase, it becomes easier and clearer to recognize. Attention should be paid on the development of warning signs and the typical laboratory changes that may occur. In dengue, typically, there would be progressive leukopenia accompanied by progressive thrombocytopenia and rising hematocrit. And liver transaminases would also be elevated. There are some surgical as well as medical conditions that could mimic dengue during the critical phase. So for the surgical cases, we have an acute abdomen, such as acute appendicitis, acute cholecystitis, and perforated viscous, and the rest are the medical conditions. So for the clinical examination, this show the quick guide in doing your examination on dengue patient. This is the 5-in-1 maneuver or your CCTVR. So how is it done? You have to hold the hand of the patient to evaluate the peripheral perfusion. You check for the color, which should be pink. Check for the CRT, which should be 2 seconds or less. Check for the temperature, which should be warm. Pulse volume should be full, and pulse rate should be within the acceptable value for age. So holding the patient's hand to evaluate the peripheral perfusion in less than 30 seconds, it can help you to assess the peripheral perfusion. You can know immediately if it is normal or reduced. So we actually have 9 parameters in the hemodynamic assessment of patients. And doing your CCTVR already helps you assess 5 of the 9 parameters. So to assess peripheral perfusion, you have your CRT, color, temperature, and peripheral pulse volume. And to check for the cardiac output, you have your heart rate, the pulse pressure, and your blood pressure. And to check for the organ perfusion, you have your level of consciousness and the urine output. And to check for your respiratory compensation, you have your respiratory rate. So this slide shows you the result or the result of patients with stable circulation. And this slide shows you the patient in compensated shock. There is reduced peripheral perfusion, which is seen as prolonged CRT, cold extremities with steady pulse, reduced cardiac output, seen as tachycardia, rising diastolic pressure, and narrow pulse pressure, and reduced renal perfusion, seen as reduced urine output. But you have to note that in compensated shock, changes are seen in all except for the level of consciousness and the systolic pressure. This slide shows you the result of patient in hypotensive shock. There is reduced brain perfusion, reduced peripheral perfusion, reduced cardiac output, and severe tissue acidosis. In short, the patient is in the compensated shock. And if this goes further or continues further without any intervention, death eventually follows. So for the management, Group A patients are those without warning signs and can be managed as outpatient. These are patients who are able to drink and urinate adequately and they don't have any warning signs. They have stable hematocrit and hemodynamic status. So what are you going to do? You have to advise them for daily follow-up and do serial CBC and give them anticipatory guidance. You also have to mention what to watch out for, especially the warning signs. Group B patients are those with warning signs and coexisting medical conditions. And also they have social circumstances like living alone or living far away without a reliable means of transport. So what should be done? You have to admit them, monitor their hemodynamic status, and correct metabolic acidosis or electrolytes as needed. So Group C patients are those with severe dengue in need of emergency treatment and urgent referral. So these Group C patients are those with severe plasma leakage, severe bleeding, and severe organ impairment. So as I've said earlier, there is a need they require emergency treatment and urgent referral. So what are your discharge criteria? The patient should be febrile for 24 to 48 hours. There is improvement in clinical status. There is increasing trend of your platelet count. So there's no need for you to wait for the platelet count to be normal. As long as you see a decreasing trend, I think these criteria should be considered. Stable hematocrit with oral intake and off IV fluids, and the presence of the rash. You can see the characteristic of the rash, which is Isles of White in a sea of red. So what are the do's and don'ts in dengue management? So for the don'ts of dengue management, don't use corticosteroids, don't give platelet transfusion for a low platelet count. Okay, don't give half normal saline. And for the do's, of course, you have to, there, you, you have to tell outpatients when to return and recognize the critical period, closely monitor your fluid intake, recognize and treat early shock and administer colloids, and give pack RBCs as our blood transfusion as needed. Sorry. Okay, I think that's my last slide. Thank you.